UCM Talks. Powerful talks, new ideas and research. This is a new initiative for UCM. It's part of us positioning ourselves as we should be, as the biggest tertiary education establishment in the island. We have loads of students, we produce lots of good outputs, good results. We impact the Manx community, and this is another way that we want to impact the Manx community. Informed people, engaged people tend to make better decisions, both as individuals, as organisations and as governments. So our idea is to showcase a range of topics. Sometimes there'll be research conducted by our own students and staff, and sometimes we get the opportunity to have a visitor, although Russell Gundry is not really a visitor. He's living away at the moment, but he's Manx born and bred. His gene pool is spoken for, so he's comes well recommended. And Russell, knowing Russell as I do, I think he's the sort of man you'd want involved in any enterprise that you're involved in. He's passionate and progressive and creative and thoughtful and just a delight to be around whatever you're talking about. So it really is lovely to have you here.
Wow.
Thank you.
And just,
I'm going to come and stay with you then.
You're going to come and stay with me, yeah. History degree, University of Nottingham, Master of Science in Business Enterprise with distinction from Oxford Brookes. Now working, Russell has his own business, but he's now working quite closely, and as in much of your time is taken up working with Google DeepMind.
Yes.
We'll talk a bit about that as we go through. So you're not here to speak about me, but just to hear from me, you're here to hear from Russell. So we're going to crack on and hope you enjoy it. Thank you, Russell.
Thank you very much. Hello, as Gail says, I'm Russell. I founded an organisation called Third Opinion, which is about helping people to design better health by making better decisions. And the reason really for today's talk is to enable people to make better decisions about how their health data is used, both at a collective level and hopefully learning something at an individual level. I asked you who was here, and you can still participate in this. So that there are going to be a few questions throughout, which you can respond to either at that link at the top, that polev.com/3RDO, or you can text 3RDO to that number, and then follow the instructions, clicking A, B, C, or D. But this is kind of interesting in the sense that we get a view as to who's here. The fact that 3 of them say 14% suggests to me that we don't have a very high completion rate, but that's fine. I mean, it probably illustrates to us that most people identify from the perspective of being members of the public, but also that we've got people who also represent themselves as either patients or carers, clinicians or health professionals, and policymakers or advisors. Now, clearly that's not a completely exhaustive list of anybody's perspectives with regard to health, but hopefully it gives us a bit of insight. And one of the things that I want to say is that I'm neither a clinician nor a data scientist. So actually within this room I'm aware that a lot of people have some very useful experience to bring to this, not least of all because of your perspective on your own health, which you are the expert in. So why do we care? Why should we care about health data? Well, it's the most valuable asset that we own, and yet we're not very good at using it or working out how to use it and connect it. And in terms of how we reap that value, there are potentially huge values to be drawn by the state from health research. Private companies are increasingly interested in what's happening with health data. And if you were to get onto the dark web, and it's not something that I know how to do, but you would potentially pay quite a lot of money for health data in relation to, say, financial data, which is kind of interesting. So there clearly is this commercial angle on what health data is used for, and the development of potentially quite threatening business models. And a challenge for us socially then is, how do we respond to that? So how can we respond in an effective way? Now this stuff is moving forward. And the challenge is how do we move forward in a sensible and reasoned way, and that's part of the reason for wanting to have this debate. The reason why I put this image here is that the social media organisations tend to have taken quite a colonial approach to data. And it's not dissimilar to the sort of the British Empire really. They sort of turn up and just generally assume that things are theirs. So a lot of your data is already being used by companies like Facebook and Google. But actually, one of the challenges that we've got from a sort of a philosophical point of view is that our health data is qualitatively different to, say, data from my washing machine. So if my washing machine sends data back to Bosch about how much water I'm using, then yes, that is at some level personal data. But it's not personal data in the way that if my eyes send information about my DNA is personal data. There is a difference there. So there are things that we might want to hold on to as individuals which are different to the data that our washing machines might tell about us. This is kind of quite a basic model, but I think that it's useful. At some level, our health data disaggregated is almost valueless. So if we consider that as a sort of a load of ones and zeros, it doesn't really have any meaning at all. And we combine different data sets together and we get information which then we can use. So effectively a health database is a load of information. By interrogating that database, we get knowledge from that. And then building on that knowledge and placing it critically into context. So from a patient point of view, how does that data help me to make decisions about how I manage my own health? Then that potentially makes us wise. So a question I asked, and you can still respond to this, is how wise are we? So again, you can participate in the same way, and we'll see if these numbers change. But most people seem to agree that we're lacking in data in terms of people that have responded to this question so far. So we've got, they're balancing out. A third of people. I'm just doing this to confuse you. 40% of people. So a lot of people say that we're lacking in data. About a third of people say that we're overwhelmed by data, and then about a third of people say that we're adequately informed. But in terms of that pyramid that I just described, then we're certainly not saying that we're wise with regard to health data. So that's kind of interesting. We've got this question mark about, well, we've got a bit of a lack of it. At the same time, we've got too much, and possibly some people feel as though they know just about enough. So it's probably not a great picture. I thought it might be helpful to describe some of the projects that I've been working on that have informed, I suppose, some of the things that I'm saying. So if this was an academic presentation, then I'd be explaining the approach that I've taken to develop these insights. Of course, it's kind of more of a project-based presentation, so I'm kind of saying, okay, these are projects that have informed this analysis and what I'm saying. So in terms of recent work, one of the big challenges with the healthcare system is not its inability to do complex analysis with data, but actually the ability of different parts of the healthcare system to talk to one another. And one of the sort of the consistent challenges, which perhaps is less of an issue for the Isle of Man and perhaps more of an issue for the UK, is how do hospitals share health information. So if you're potentially receiving care from more than one hospital, then it's unlikely that those hospitals can connect to your patient notes. And so there is no single entity at the moment which will have your patient information in. And it's quite complicated to do that because you've got a number of legacy systems, none of which have been designed to do that. So what the care system is trying to do is to develop open APIs, which effectively are a means of connecting information systems together using common standards. Is that a sort of clear enough description? So often based on what the banks have done in terms of how they match different data sets together. And by doing that, if we take this, what we did in terms of this project is went out and asked a lot of clinicians, well, okay, so where do you experience avoidable harm as a result of not having real-time information updated? And in this case, it's talking about an avoidable allergic reaction by virtue of not sharing data, and then a number of delays in things like transfers of care between different care settings that happened as a result of that. So it's this kind of series of errors. I'm reluctant to say the word comedy because it's not funny, but actually these things are in some respects quite basic, and they're really not to the level of this kind of like this comprehensive picture of what we could do from a statistical point of view with advanced manipulation. So that's what NHS England are up to. In terms of other work then with NHS England, we were looking at how do we develop a sort of a system response to things like type 2 diabetes. Now this is a very, I suppose it's quite a complicated diagram, and it's not necessary to see to see all the words, but effectively what it's saying is that if we place the sort of service user in the centre of this picture, and then we use data to inform the way that we make buying decisions, and then on the basis of that intervene in the way that the service is delivered in order to keep on improving the service around the needs of the user, then we're developing this kind of this system map, if you will, to improve challenges like type 2 diabetes. And one of the issues that we have in the West is that our sedentary lifestyles are related to about 80% of the cost in the healthcare system. So there's this sort of big challenge around where would we intervene in this system in order to make a tangible difference. And actually there probably isn't a single point, it's probably a multifaceted approach. I think the Sickle Cell Society, this is quite interesting in terms of a very sort of different perspective. So sickle cell anemia is a lot less prevalent than type 2 diabetes, but it's the biggest congenital blood defect affecting the population in England. One of the challenges is that it primarily affects a West African population, so not only have we got the challenge of the fact that these people are dealing with quite a difficult genetic condition, but also potentially there are issues of race and exclusion in there. So we've got questions about how do people with sickle cell anemia get appropriate representation from a patient perspective. And critically, much like type 2 diabetes, there's this challenge of how do we manage care in the community, which is kind of, it's like easy words to say and hard to do. If people with sickle cell anemia are under stress, they're more likely to have a crisis, which means they're more likely to end up in A&E. And that's a bad place to be if you're immunosuppressed. So how do you keep people out of A&E? Well, effectively making sure that they're not stressed would be an effective way of doing that. And yet the business case, if you wanted to look at it in very financial terms, for investing in community services that have preventative results, it's very difficult to prove, because effectively what you're saying is, I need to prove that I'm keeping this single individual out of hospital and avoiding a costly length of stay in hospital, but actually it's very difficult for me to prove that it was that one individual by virtue of the fact that I don't have the data that says that it is, nor can I connect the data sets that say that it is. So actually I can't prove it. And so we kind of go around in this kind of perennial circle with these questions. The fourth thing to mention then is work with DeepMind Health. So DeepMind Health are probably the leading artificial intelligence organisation in healthcare, possibly not with regard to specific developments. I think there are probably niche organisations in a number of different areas that are doing some very interesting stuff. But in terms of scale, they're acquired by Google in 2014, so they've got an enormous scale behind them. And they're doing some very interesting projects that are pushing forwards both advanced technology and artificial intelligence in healthcare. Now, one of the challenges with that is that it really changes the way that we think about the way that healthcare is delivered. So from a sort of governance point of view, or how do we regulate it, it's actually very difficult to determine. And so there are a number of quite challenging issues around that. So what we were doing with DeepMind Health was building patient representation. So ultimately saying, patients are the people who need to benefit from this service, but it tends to be defined by people who are researchers, who by definition tend to be male, middle class and white. So a challenge around how do we ensure representative benefit to patient populations from the work that we're doing. So in terms of where we are now, so the Information Commissioner's Office says that people have never been so aware of what their personal data is and never cared so much about how it is used. Now that's kind of interesting to compare that with your earlier analysis that actually we are on the whole either lacking in data, overwhelmed by it, or in the best case scenario we've got just about enough. So actually there seems to be a bit of a disparity there, potentially, in terms of the way that the information commissioner is thinking about it and the way that we are thinking about it as a bunch of people. And I don't think that refutes your analysis. The Wellcome Trust is leading a very interesting initiative called Understanding Patient Data. I would recommend anybody having a look at that, actually. So that's really interesting in terms of the way that they're trying to get generally understandable content about what patient data is and how it is used, accessible to the public. So in terms of what you said about your feelings about health data, so now this actually is unusually positive. So in terms of people in this audience, okay, that's good to get some opposition. Thank you, that's it. That's basically, yeah, makes life more complex. So half the people are saying they're positive. Well, can we get some words, some verbal feedback? Why would people say that they're strongly positive about sharing health data?
My reason is because I want the health professional I'm seeing to have all the data they need. And at the moment, where it's not shared between services, they often don't have the information they need to provide a good service.
Yeah, it makes sense. And I think your perspective is pretty informed, as well as from your perspective as a healthcare professional. So it's interesting that with information you're making that assessment.
Yeah.
Any other views in terms of a sort of positive perspective?
I can't see why it would be negative. I can't see why showing information in this area could possibly be negative, because by showing more data, it's only going to feed more positive research. And as long as, I'm pretty positive on it. I just can't really see a negative. I'm sure there is a negative.
Okay.
I'm just not informed enough to know it.
We'll come back onto what some other people said about the negative perceptions as well in a moment.
Yeah, my thought would be the same as Richard. I would want to enrich the practice by sharing data, but I'd be concerned about confidentiality and protection.
Okay, so that is a kind of, that's a balanced perspective. So confidentiality and protection. Okay, so that's
particularly in an island community like ours.
Yeah, good point.
Small community. I think you're talking about much larger NHS, aren't you?
Generally, yeah, absolutely. So if you're in London, then it's unlikely that the person who's accessing your data you're going to know, or they're unlikely to know a member of your friends and family. But on the Isle of Man, then it's highly likely. So it's a very different dynamic. That's a good point. Okay, so I suppose it is impossible to present the whole spectrum of what everybody thinks clearly. And one of the interesting things that we found when working with patients, in particular patients with long-term conditions, was that they were very positive about sharing their healthcare data. Now, I suppose you could say that that's not particularly surprising because there's a direct benefit. So from their perspective, if they've got a long-term condition, they're saying, well, actually, I would like you to share my healthcare data in order to improve my health. I would also like to share my healthcare data in order that might improve the health of somebody else who has a similar condition to me. So there's a kind of clear and direct benefit from that sort of patient perspective. One of the things I would also add to that, though, is I think all of the patients that we spoke to, most of whom knew actually quite a lot about healthcare data, also raised those issues about confidentiality. So they also said, my assumption is my data is handled in a robust and effective way, which of course then that kind of, it captures the concern as well, but probably in quite a positive construct. Public are more cautious, and I suppose, I've kind of not covered all of the positive statements that the public have made, because it's perhaps more interesting within an hour-long presentation to cover some of the disparities. But in terms of some of the issues that they mentioned, the key one is people being concerned about their health data being sold to insurance companies. And particularly when the NHS in the UK is moving more towards what looks like an insurance-based model as they have in the United States, then there are challenges in terms of, okay, so if I provide data to my insurer and that reveals an underlying health condition, then do I potentially become uninsurable, or do my premiums go up? So there's, I suppose, a direct question there about, well, am I prepared to share my health data in that context? And that typically will be more of an issue for people in middle age than younger age, because they're more concerned about those issues at that point. I think that the sort of the marketing point now is quite similar. So will my health data be sold and used for marketing purposes? And people are already probably being a bit stung by Facebook and similar, and the way that the targeted marketing of social media is improving, and they're expected to see that in healthcare. There's also this question about data linkages. So actually, you start to see with people like Vitality, they offer discounted health insurance on the basis of people joining gyms and doing more physical activity, because of course that reduces the risk and reduces their premiums. But actually, you know, if my data is linked and my insurer has access to that, and then I go and scan, you know, a cake at the checkout, do I necessarily want that level of scrutiny over my personal behaviour? And then also using commercial health products. So I suppose, you know, you could think about this in a few different contexts. So from a sort of fitness point of view, if I'm just using a Fitbit, then could somebody retrospectively link that data to my health record and understand whether I was or wasn't exercising? And similarly, actually, there are a lot of, or increasingly a number of health products available on the market that you can buy as an individual consumer. And presumably then your purchase means that actually that data should be controlled by you, as opposed to taken into some entity that you don't recognise. So those were, I suppose, some of the questions that were raised. I think it's probably interesting to talk about how the public has seen this. I mentioned Facebook and social media, and there's this sort of question about how this stuff is processed. So in terms of the work we've done with patients, we talk about deleting data. Then I think people are increasingly aware of the fact that actually that's quite a difficult process to do. And also challenges around, for example, Facebook will maintain your profile information even if you do delete it. And not only that, but they will maintain shadow profiles of people who aren't even on Facebook, because the value of their information is relational. So what they're interested in is, how do you relate to other people and how do you share information with other people? Because ultimately, they want to know how you make decisions. And I suppose if we were thinking about the sharing of data to that sort of nth degree in this kind of social context, then there's the possibility of people, even without passing on their medical data, still being identifiable at some level. And I think, rather than sort of painting a doomsday scenario, what is probably more helpful to say is that, you know, this stuff is happening anyway, even without action on our part. So we need to be able to recognise that it's happening and respond appropriately, whereas effectively kind of burying heads in sand and backing out of that system is probably that's probably already gone past. So in terms of how the healthcare system sees you, and I suspect, I think a lot of the people in this room probably already know this, but in terms of a sort of a journey, as far as the healthcare system is concerned, at some level, you are well and fit. It is a sort of baseline assumption, up to the point at which it will be flagged that you would need some form of primary prevention, which might be weight loss to avoid further complications later in life. If that doesn't work, then the likelihood is that complications will arise. So then there's kind of secondary prevention. So how do I then keep you out of hospital is effectively the mentality that it's looking through. Then potentially you might end up with a level of stay in hospital, and once you've done that, then you'd be rehabilitated. And clearly, in terms of the way that data is shared within those contexts, then you've got everything from well and fit. You might use fitness devices to track your heart rate and your vital signs, all the way through to medical devices and level of stay. And at some level, rehabilitation is increasingly using user-driven devices that may also become consumable. One of the interesting things in terms of, if you to look at this from a consumer perspective, is that whilst people invest a lot of money in maintaining wellness and fitness, typically that falls off at this primary prevention stage. So GPs typically will say, actually, whilst people are prepared to pay thousands of pounds for a carbon fibre road bike and the accompanying fitness metric equipment, what they're not prepared to do is invest in their own blood glucose monitor, for example. So the perception, or prevailing perception, tends to be that that's the responsibility of the state. So it's not exhaustive, but it's just an interesting perspective from a consumer point of view. Clearly within this, as far as your healthcare data is concerned, you also are born and you die. But that's sort of I guess a reasonable approximation of how you're sort of seen through the system. And one of the things I wanted to point out with this is that the emphasis here is on prevention. And I suppose if we look at how the meaning of the data is structured, then if we assume that there's a latent demand for people to do something, to have these unhealthy lifestyles, which is effectively a result of the way in which we live our lives, and the system is trying to intervene to prevent it, then inherently that would appear to be an ineffective approach. So one of the questions we might ask in terms of the way that data is structured is, well, how do we derive meaning from data from this kind of preventative point of view? Can we really stem the tide of demand, or actually do we have to find a different way of dealing with this? I think does this make sense to people? I probably won't go through it. So, at one level you've got medical information, patient information, health record will tend to be a conversation that you have with your GP, so a wider perspective on your healthcare. Biometric data would be what you would put into an app if you were managing your diabetes. Genomic data then, if you supply your DNA to 23andMe for analysis. And then increasingly social data. So actually if you look at what now sentiment analysis can do with things like Twitter, then they'll use tag words to identify if there is likely a flu epidemic, for example, about to hit, with varying degrees of success, frankly. But that's interesting, I suppose. So non-health data being used for health purposes, and limited success, but actually seems to be improving. So it's an interesting question in terms of how it might extend the definitions. So I suppose it's, rather than go into this in more detail, what I wanted to say was that there is a distinction between data which is personalised and data which is depersonalised. And rather than reading this, which I'm sure you're more than capable of doing, what I'll say is that personalised data is typically required to administer treatment to you, and depersonalised data is not. Now, depersonalised data then is applicable for research purposes, and there are some interesting questions in terms of what that means. So, for example, you would have to provide your data, your consent in order for your data to be accessed, in order to be taken from you and then used. But at the point at which it's then anonymised, you don't any longer need to give consent for that data to be used. And that's because it can't be attributable back to you. From a consent perspective also, it's important to say that if you're receiving care, then implied consent also applies. So in order for you to be treated in hospital, even if you turned up and you were not conscious, then it would be implied that you had given consent for your data to be used in order that you could be treated. But actually that question of what is direct care is a sort of tricky issue that actually is probably one of the sort of knobs about, well, okay, if we're using data to improve healthcare and it has a possible future benefit, then where does this distinction between direct care, i.e. treating me, and indirect care or research come in? So, personally identifiable, I can see it's you. Depersonalised, I get a rough sense of who you are. And then anonymous, I can't really tell. So at a population level, if I want to analyse your data, I'll be using anonymous data. The challenge there, if I anonymise the data, is it's very difficult then to go back in and say, okay, I've come up with this insight about you as an individual. I can't then repatriate it back to being personally identifiable. One of the issues here, though, is the way that these different sets of data can be connected is improving all the time. So the anonymisation that we thought was appropriate 5 or 10 years ago is probably no longer appropriate now. And with artificial intelligence, the way that it's able to connect data is improving on a regular basis. So actually, if we were to go into these type of questions and say, well, actually, we need to have absolute certainty over what the situation will be in 20 years' time, well, we can't, because that's the definition, surely, of research, that we're asking a load of questions that we don't know the answers to. But clearly, we need to balance that knowing with trying to place the most acceptable parameters around it that we can. So I suppose there's sort of like that. So that's kind of starting to then get into what are we able to do with data. And the reality is that the current picture in your average hospital is some way from that. I thought that this was kind of like quite a good representative example. So typically, as consumers, we're used to taking computers out of the box and being able to use them straight away. They're intuitive. It's not typically the case with clinical systems. They tend to be very clunky. Often clinicians will be using 5 different sources of data in order to piece those things together to present a picture of a patient, and clearly that takes a lot of time. There was a recent time and motion study of a teaching hospital that was reasonably exhaustive. I think they did 700 hours of observations and found that of a single day, then about 5 hours of a single clinician's time would be spent looking at a computer, and less than 2 hours would be spent dealing with patients. Is that? I mean, what clinicians in the room? What would you say? Is that fair? Is that not fair?
I wouldn't say the ratio is quite that bad.
No, I think that was an extreme example.
Even on the Isle of Man, there's all the different parts of the health service have a different computer system, and they don't talk to each other, so it does present a difficulty.
Yep.
And your time use isn't effective.
Yeah. Yeah. Okay. So sort of broad agreement, but sort of overstatement of proportions.
Yeah.
Yeah. Okay. So in terms of what we can do about that, it's probably helpful to distinguish between application and an algorithm. So at one level, having that information all available in one place is helpful as a start. So if I don't need to look in 5 different places to get relevant information about a patient, then that's helpful. The benefit then potentially of having that information in one place is that then I can apply a set of rules to that information, especially if I've got a very large data set, that then start to improve the way that I analyse it. Does that make sense? Is that clear? Not clear? Reasonably clear. So if we take acute kidney injury as an example, so that's a kind of a rapid breakdown of kidney function, effectively leading the body potentially to poison itself. Kills about 40,000 people in the UK a year and costs about £1.25 billion to the healthcare system. And one of the sort of quite annoying things about acute kidney injury is in many cases it's quite avoidable and might result from simple dehydration or something similar. One of the challenges is that we might have acute kidney injury sat here and we wouldn't know. The symptom will be starting to feel slightly unwell initially, and it needs to be tackled at that point in order to take corrective action. The way in which it tends to be identified is that you would have a blood test taken. That blood test would be sent off for analysis. Those results would be looked at by a specialist, and they will returned back to where you are. Presumably, at this point, you might be in a hospital, and within that, then there are several days of avoidable delays often encountered. So what we can now do is analyse every patient's data as they're admitted to hospital and their blood tests are taken. As soon as the blood tests are taken and an abnormal result is detected, then that would effectively flag an alert on this application, and that then goes back to the clinician in order that they're able to make a quick decision. So effectively you've got A, information in one place, B, alert, and then C, the ability to triage people, so to escalate or de-escalate their care accordingly. So I suppose that's an example of what we can do. In terms of where that's being used, the feedback from clinicians is having access to that technology can save them up to 2 hours a day, so of that sort of 5 hours of computer time. But there are some challenges in that. So effectively, in order to test this type of technology, then we're effectively implying the consent of almost a whole population that uses that hospital. And so there's a real question mark from a sort of philosophical level about, have those patients given their consent for their data to be used in order for this technology to be developed? And that's a question which a lot of people are spending a lot of time trying to address, but that's the type of issue that we're grappling with. There have been some big developments in artificial intelligence recently, and so chess is not a new one, but the big change is that we now have general artificial intelligence, and effectively what that means is it's able to learn. So you might have seen in the news recently that an AI was able to learn the game of chess in 4 hours with no prior human input, up to the point of beating a chess grandmaster. And within a day, it's able to achieve superhuman levels of performance, and that's effectively displacing thousands of years of accumulated human knowledge. So at some level, that's pretty impressive. And one of the big changes in its ability to do that is the ability of artificial intelligence to play itself. So effectively, over a very short space of time, it's rapidly improving the way that it develops its strategy. Now that's kind of helpful, but clearly being able to play games like chess and Go is useful to some degree, and they're very complicated. So chess has more potential moves than there are atoms in the known universe, but they're finite and they have defined rules. In terms of where we then develop that, so we can take that to things like retinal scans. And it's probably not that difficult to see from the images that actually looking at a retinal scan, the way in which that imaging is conveyed is actually quite uniform. And so the rules, the boundaries of that system are quite easy for an artificial intelligence to interpret and say, that eye has a hemorrhage and therefore I know that it's abnormal and therefore I know that action needs to be taken. And an AI can effectively evaluate millions of these images in the space of time that it would take a clinician to evaluate very few, and now with better results. However, there are some challenges with that. So actually, if we take that to a more complex set of analyses, so if we look at things like blood tests, or if we look at things like patients with multiple presenting symptoms, or if we look at patient-generated data, then actually we're developing this much more complex picture that looks outside of what is a very controllable environment. And that's where effectively AI can be an assistive aid, but doesn't present a whole solution. If you apply to populations, I mean, this is kind of, I think it's probably just worthwhile flashing this up quickly, but effectively what this is saying is that at street level, I can tell where the people with diabetes probably live, and with the people who are about to develop diabetes also probably live. So we're sort of seeing high resource utilisation here, high cost effectively to the healthcare system, and then here we're seeing, okay, so these people are at that level where their costs are starting to increase, and so they're likely to be in a high cost situation, less corrective action is taken. Now, one of the challenges is that if you ask a GP, then they might tell you, well, actually, I can kind of walk down the street and tell you who is likely to get type 2 diabetes. So at some level, this analysis, whilst being very complicated, is not perhaps necessarily useful. So again, we come back to that challenge of, okay, so whilst this sort of artificial intelligence approach to data may be very helpful with this kind of constrained data sets, actually, if we take this into, well, how do we intervene in a population, then it doesn't necessarily answer all the questions that we need to. I'll say quickly, as a consumer then, if you want to take your health into your own hands, then there are a number of entrepreneurial organisations that will help you to do that at varying levels. So you can spit into a tube and send it off to 23andMe, and they will tell you your likelihood of developing Alzheimer's and Parkinson's, amongst other things, as well as tell you information about your ancestry. So effectively what you're doing there is contributing to a research database that is set up by the ex-wife of one of the founders of Google, and you're paying for the privilege of doing that. But equally, the benefit that you're getting back is your health information. I suppose one of the things that worries me is that the state, whilst it has this perspective that health data is very valuable, doesn't seem to be demonstrating this kind of entrepreneurialism of this kind of thing. So effectively, at some level, we could end up in a position where people are paying to give their money to give their data to commercial organisations who then host it and then can effectively do what they like with it, but perhaps without the users understanding the process that they've been through. Also, and I'll wrap up, HealthWiz. Has anybody seen this one? This has come out quite recently. So one thing is a patient record where effectively they're responding to the challenge of, as you said, Lottie, that people cannot connect all of their different health information in one place, and they recognise that that's frustrating, so they decided to do something about it. But what they've also done is create a platform which enables people to sell their health data. So what I was saying earlier about your health data having no value, well, it's of no value unless you can place it into a platform, which is effectively what they're doing. And they're using blockchain-based technology similar to the technology that cryptocurrency uses in order to place tags against your information. So if you think about that, then it's effectively saying even if you anonymise my data, so you can't recognise that it's me, I can still see that you've got that tag and that you own it. So that's what these guys are doing. So I suppose it presents some quite interesting models in terms of the way that data can be handled. So I guess to sort of like to start to bring it into a conclusion, that'd be good to I think, have some questions, but also hear what you think. If we look at sort of where leaders are in the UK, they're saying advanced technology is definitely a big part of the future of healthcare, but actually the ability to have electronic health information, the ability to connect it, and the ability to fundamentally have good data on which to base good decisions must take priority. We need to focus on better outcomes, and it's kind of an easy thing to say, but what do we actually mean by that? And I would say that actually, within a bounded community like the Isle of Man, the ability to determine what we mean by good health is a clear opportunity, whereas within a much larger population the size of the UK, it's much harder to achieve that level of consensus, and you can dispute that if you think I'm wrong. There's this question about business models being developed, and it might not be the right way of phrasing it, but effectively we're seeing a lot of organisations with commercial interests, and there's this question about how do we work with them, because they're clearly very good at developing this entrepreneurial technology, whilst also holding them to account. And also values are critical, so we're sort of moving away from this kind of colonial approach to data to a perspective where people needed to be just treated with respect, reliability, consistency, and presumably integrity. So at some level, just recognising the value of people's data and what benefit it can have to them. The point I wanted to make with this was just to conclude by saying that that this is partly, I guess, from a sort of data perspective, and there is sort of a sheer data which is kind of zeros and ones, but from a healthcare point of view, presumably if vets are good at administering health, then they're not receiving effective data from their subjects. So there is more to this question than simply data science. And if we fail to recognise that, then we're missing a big trick. And so effectively, in terms of the way that we structure how we think about data, a very, very simple analogy again, but actually if we think about the way that we collect it, what we use it for, how we connect it, if we start with, well, why do we need it? What are we trying to do with it? That's not an unreasonable place to start. Then that informs how we collect it and then what we do with it. And actually, I would say even if we're to look at complex pieces of EU legislation, for example, with this lens, like GDPR, then actually that's quite a helpful lens, because it's a very, very complex picture on one level, but actually all it's really asking is, why do you need the data? How are you going to use it? What are you going to use it for? And actually, if we take that perspective, then that helps us endlessly. That's all I wanted to say.